Hi, my name is Zachary Town, and as part of the Health Equity curriculum, today we will be discussing tobacco and smoking cessation. So at the end of today's lesson, you should be able to achieve these objectives listed below. Some of them describe the burden of tobacco use on the individual and public health, along with benefits of quitting, some of the barriers of quitting, how do we screen for patients, some tools like the CT quit line, and then a application of intervention skills like the 5A's in motivational interviewing. So, as always, let's begin with a discussion of why do we care about tobacco? Well, an estimated 49 million US adults still use tobacco, and 34 million still smoke, and 34 million itself is over 10%. Smoking remains the leading cause of preventable disease, disability, and death in the US, and accounts for 1 in 5 deaths every year. Along with that, over 440,000 premature deaths every year. It's estimated to be the causal factor in 30% of all cancer deaths, and even secondhand smoke has an estimated 49,000 lung cancer and heart disease deaths every year, so it adds up very quickly. So this slide is showing a table that describes the relative risks of smoking, both by status and age. Notice that this is for women specifically, and that we have multiple age categories. So I highlighted a few just to point out, but of course it's worth stopping and going over all of them. Something particularly worth pointing out is that the relative risk for women in their late 30s for lung cancer is 13.30 compared to the 2.64 of former smokers. So this is basically multiple times the risk when smoking compared to a former smoker. So beyond just the risk to the individual, there's an enormous burden on public health. All told, the estimated cost of tobacco use is $386.6 billion every year. And from estimates from 2014, we can see that direct healthcare spending is $225 billion. And even something like secondhand smoke exposure costs is $5.6 billion. And while that is the societal cost, I thought it was also interesting to point out the average cost of cigarettes in the US. So in 2020, the cost of a pack of cigarettes on average was $7.50. And if you smoke a pack a day for an entire year, you're looking at over $2,700 for individual costs. So while tobacco use has a large economic burden on public health, there are various government policies that help to decrease tobacco use. Increasing the taxes and prices of tobacco products lead to reduced initiation, prevalence, and intensity of smoking. Broadly speaking, a 10% increase in price is associated with a 3 to 5% decrease in consumption. There are also various policies and laws that reduce the prevalence of tobacco use and initiation. Some of those healthcare policies include the HITECH Act, which requires identification and documentation of tobacco use in the electronic health records for patients 13 years or older. So this helps with the continuity of recognizing who used or uses tobacco. And the ACA mandates coverage for tobacco cessation medications in state Medicaid programs, and also coverage for nicotine dependence for pregnant smokers with no cost sharing. And then it eliminates the copays for preventative services that have been approved by the USPSTF. And then Medicaid specifically expanded coverage of tobacco cessation to all beneficiaries. So now I'd like to move on to some of the benefits of quitting. First up, we're going to discuss just cancers in general. So smoking cessation is beneficial at any age, and it can add up to a decade in life expectancy. And then the risk of cancers steadily decrease with cessation compared to those who continue to smoke. So lung cancer, one of the big ones, the risk halves in 10 to 15 years, meaning within 10 years, former smokers have half the risk compared to those who continue to smoke. And then laryngeal cancers have in about 5 years. And then various other cancers will fall in between that time frame. And this is just some data for you. So this is a graph showing the relative risk of lung cancer incidence or mortality. So there's multiple by number of years since quitting when compared to those who continue to smoke. So we look at 0 years, meaning they just quit or have continued to smoke, and that's going to be your relative risk of 1. And then as we follow for mortality, we see that it decreases to the point where in 35 years, you're at a third to a tenth of the risk, depending on which study. So cancer isn't the only disease associated with tobacco use. There's also cardiovascular diseases. Broadly speaking, tobacco cessation reduces markers of inflammation and leads to improvement of high-density lipoproteins, aka your cholesterols. And this is shown to reduce the development of subclinical atherosclerosis and also slows the progression for clinical cases. Closely connected to that is stroke, and so it's been shown that stroke risk drops to almost baseline, aka as if you've never smoked, within 15 years. Your coronary heart disease, aka CHD, risk is halved in just 1 year, and at 15 years it also returns to baseline. So in patients with coronary heart disease who smoke, cessation leads to reduction in all-cause mortality and reduces new or recurrent cardiac events. So if you are diagnosed with coronary heart disease and then quit smoking that moment, you still see these overall reductions. But while there's some serious positives to quitting, that doesn't mean that there's no negatives. So this slide just briefly goes over some of the barriers associated with quitting. And so what are listed here are reported barriers. So we see that in the enjoyment of smoking remains as one of the highest barriers to smoking, where cravings closely follow, along with stress management at topping out at 63%. And then we see withdrawal and irritability close by. We see also the risk of gaining weight. It's been associated that patients may put on 5 to 10 pounds within the first year of tobacco cessation, but we regard that weight increase as a far lesser evil compared to the continuation of smoking. And that's something you can address with your patients as well. And then finally, there's the fear of failure. A lot of patients try to quit, as we discussed before, but aren't successful, and some may feel discouraged by having to try multiple times in order to quit. But like we've talked about with counseling before, sometimes lapses are expected and they're normal, and we can help walk patients through that fear of failure and try to help them be more comfortable with it. So as I alluded to on the last slide, there are some barriers to cessation. Yet 68% of adult smokers report wanting to quit every year. And in fact, 55% have attempted to quit in the past year, yet only 7.5% of smokers successfully quit. And so there's a serious discrepancy there. And it's worth pointing out that less than a third of adult smokers use cessation counseling that we can go over in this presentation today, or medications approved by the FDA when trying to quit. And so on this slide are just a few of the statistics for whether they use counseling or medication. And so the idea is that we can use the counseling and medications to help address those barriers above and help people quit. So what exactly do we do if someone wants to quit? Well, we screen. We ask all the time, are you using tobacco? And from there, we use counseling techniques like the 5 A's or motivational interviewing to help them both address how to quit and how they feel about going through it. And then, if needed, it's not as common with tobacco use, we can refer them to treatment. So, screening in primary care. Luckily, this is not the difficult part. We can use the ESPERT protocol and simply ask, do you smoke cigarettes or any other tobacco products? And it's widely accepted that all adults should be screened routinely for tobacco use. Those who use should also be encouraged to quit at any visit. Really, we want to use these visits in primary care as the opportunity to help people to quit and to warn people about the tobacco usage and its harms. So in addition to screening for tobacco use, for those who do use tobacco, there's an additional screening that we should discuss. The USPSTF recommends annual screening for lung cancer using a low-dose CT for adults, but it's adults within a particular population. So they have to be between the ages of 50 and 80 and have a 20-year smoking history and currently smoke or have quit in the past 15 years. So if a patient falls within that, meaning say they're 65, they currently smoke and they've been smoking since they were 30, then you should recommend this annual screening to screen for lung cancer. Now, that recommendation stops once the patient hasn't smoked for 15 years, meaning if they stopped smoking when they were 40 and they're now 70, no longer need to screen. Now we're going to review a few different ways to counsel. So you have a patient who uses tobacco and say they're on the fence about if they want to quit. So we can use some techniques like the 5 A's, the 5 R's, and motivational interviewing to counsel them through, to guide them through the process of quitting. And just brief review, the 5 A's includes ask about usage, advise or support cessation, assess the pros and cons of usage, then assist them with resources, and then arrange with a follow-up plan to help them. And now the 5 R's are ways to help motivate patients to quit. So you want to identify reasons to quit. You want to point out the harmful effects of use or the risks. You want to point out the benefits of cessation or the rewards, explore the barriers or roadblocks, and then use every visit to repeat the message and to help motivate. So the first step of the 5 A's is ask, and it's very similar to the first step in ESPERT. You can ask, have you ever been a smoker or used other tobacco products? If they say yes, you can ask, do they smoke now? And then how much? So you're just doing some information gathering. The second step is the advise, and so in this case, you're providing your support for cessation, and you're trying to do it in a neutral tone. So you could say, I think quitting smoking is very important for you because of your asthma. Notice here that it's tied to a personal health risk. And then follow that up with, I want you to come back to the office next week so we can talk about this more. So it can be helpful to set up a separate visit in order to discuss it further. And then perhaps during the next visit, you move on to the assess stage. You're going to continue to gather information. Have you ever tried to cut back or quit smoking? Are you willing to quit now? What keeps you from quitting, which can help you identify those roadblocks later on? And then a method of identifying the severity of use is how soon after getting up in the morning do you smoke? So how it helps identify how quickly they need it. So the first 3 steps of the 5 A's can go rather quickly, but assist, the 4th step, can take some time. You can start by saying, I'd like to help you quit. Can I tell you some of the things we know that will increase your odds of success? Or you can go with, are you worried about anything in particular when it comes to quitting? Do you worry about cravings or weight gain or any of the other barriers that we know of? And from there, you can offer your support and be sincere, be genuine, because we do want them to quit. And then you can provide additional resources. And then you can always counsel on depression, weight gain, and withdrawal. So depression will become more prevalent. They may have a depressive episode. Like I mentioned earlier, they may gain 5 to 10 pounds of weight, but we have some techniques that can help prevent that. And then we want to give them some strategies to deal with withdrawal. So withdrawal peaks within the first week and can last from 2 to 4 weeks. And during that time, we just want them to focus on some other health behaviors. Like I mentioned, they're more likely to have a depressive episode, but some of our pharmacotherapies like Zyban can help prevent against that. And then, as I mentioned, the weight gain is expected, but it poses a lesser threat compared to smoking, and pharmacotherapies can also help prevent that weight gain, which is another reason to recommend them. So here are some general resources we can actually provide. The main one is the 1-800-QUIT-NOW line. So it's a toll-free number, and it will connect your patient directly to your state's tobacco quit line. And then through this phone call, they'll be connected with coaches who can help the patients create cessation plans. They will also connect the patients to over-the-counter pharmacotherapies or healthcare providers who can further discuss pharmacotherapies with them, and also point them towards community programs that will help with social support. Likewise, there's a government website, smokefree.gov, that will connect patients to resources on nicotine replacement therapies, aka pharmacotherapies, and then also counseling, and then help them create plans as well. So there are numerous pharmacotherapies that can help patients quit. I'm just going to go over a few of them. You can pause to read about doses, but that's not the main takeaway from this slide. So as far as nicotine replacement therapies, or therapies that will contain nicotine and then typically step down over time, include a transdermal patch, so you wear it on your skin, a lozenge, or something you put into your mouth and kind of suck on over time, gum, which I think we all know what chewing gum is. This one will contain a small dose of nicotine, and then a nasal spray. As far as the non-nicotine replacement therapies, we have Chantix and Wellbutrin. These are both interfere with how nicotine is processed in the body. Chantix is a nicotine agonist, and so it actually competes with nicotine in the body. And then we have an antagonist in Wellbutrin. They both have their particular counter indications, and so before prescribing them, it might be worthwhile to look those up. And then finally, we have a bit of a gray area with electronic cigarettes. This is reserved until all other treatments have failed. It's not FDA approved. People really should not switch directly from smoking to e-cigs. And there'll be a slide towards the end that go over some of the more information about e-cigarettes. So, after you've gone through the assist step and given the patient resources that they find valuable, you can move on to the last step, the arrange step. The arrange step is simply arranging for a follow-up visit. And you can select a few different dates. It can be on the patient's quit date or when they first start, or a week or two after they quit to check in. And really here it's just making sure that they're set up for success. So you could say something like, I'd like to meet you in a week or talk to you by phone on your quit date. What problems have you had? Are there any situations you worry about confronting without cigarettes? Really help them try to identify some of those roadblocks and really set them up for success. Now, typically a patient isn't going to leave and quit that day. In fact, it's not typically recommended. So this slide shows a few different techniques, or really strategies they can employ to help them quit and to set up for quitting. So arranging for that cessation date. First, you can provide them with a calendar and mark a quit date, and then mark a date to start the nicotine replacement therapies, or a date to pick them up from the pharmacy. You could also have them mark particular days where they may be able to clean their home and clean out their car, and remove some of those triggers like ashtrays and lighters that are going to smell like cigarette smoke or may just remind them of it. And then, of course, you can always give them the office number and have them call the office if they're struggling at a particular moment. So in addition to the 5 A's, you can also use motivational interviewing. So this is just a brief overview of motivational interviewing. If you need a refresher, you should check out the video on promoting healthy behaviors. So motivational interviewing is all about strengthening the patient's motivation and commitment to change. So when you're talking to them, you can use open-ended questions while affirming their interest in cessation and then reflecting on their feelings. And as you go through the interview, you can help them see the discrepancies between their behaviors and their values, but make sure to always ask permission to present the information so that they feel as though they're in control of the conversation. And then, like the 5 A's, help them establish a plan to quit. You could remind them of their desire to quit and provide some of those similar resources along the way. Now, say you have a particularly resistant patient who really does not want to quit. Well, the 5 R's can help really boost that motivation specific to tobacco use. So the first R is relevance. So you're going to encourage the patient to identify personally relevant reasons to quit. Maybe they have a personal risk of disease or family risk of disease. And you might want to point out whether there's asthma in the house, or point out that if they have kids, that secondhand exposure is harmful. And then you want to continue with the risks. So at this point, you're advising them against the harmful effects. So rather than pointing out what's there, you want to point out the broader risks. And this can include measuring their pulmonary function, as well as describing the effects it can have on the patient, their family, and their friends. And you're not just going to point out the negative, so the next R is rewards. You can ask the patient to identify the benefits of cessation. You can point out their improved health, that they're going to save financially, and that there'll be cosmetic appearances as well. Their teeth won't be as yellow, neither will their nails, which I would think would generally be a positive thing. You would also want to explore some of those roadblocks that they may see as barriers in the way, whether they've tried to quit before, or if they're afraid of withdrawal symptoms, or just stress from life and the job, whether they have low motivation, or whether they're afraid of weight gain. So take this opportunity to point out how you can get over some of those barriers. And then finally, the last R is repeat. And it just stands for repeating through these strategies with your unmotivated speakers. Continue to do so. Wear them down over time while being genuine and supportive to help them quit. So these last two slides are just concerning e-cigarettes. I mentioned before, e-cigarettes are not a recommended cessation tool for patients. They are just ways to deliver nicotine into the body. They obviously still contain nicotine along with some other possibly harmful substances. There's still research going on as far as the long-term effects, but some of the substances found in the vapor include ultrafine particles, diacetyl, which is responsible for popcorn lung, if you've heard of that before. There's volatile organic compounds that are responsible for potential cancers and tissue damage. There are known carcinogens, and then there's heavy metals. And e-cigarettes include vape pens, something that's become popular with young adults. And it's worth pointing out that the nicotine in Juuls, which is one of the popular products, can contain 20 times the concentration of nicotine compared to cigarettes. So it's not as though these things are harmless. And finally, I just wanted to include a slide that has some of the potential e-cigarettes on them. So you may hear them be referred to as tanks or mods. These are still e-cigarettes. They have a liquid that contains nicotine and those other harmful substances that are vaporized and then inhaled. You may also see rechargeable e-cigarettes. They might look like a USB device that's shown in the middle, or these pods. And then finally, you may just see disposable e-cigarettes. They're going to look just like a cigarette, but they're going to be made out of plastic. The reason why I included an image rather than just a description is to point out how playful some of these look, and this has been attributed to the increase in young adults who use e-cigarettes. So just be mindful of seeing these in public and who uses them. But otherwise, that's all I have for today. Thank you for listening.